Welcome, everybody. Thank you for participating. Uh, I would like to welcome all the alumni, all our friends, our colleagues, and our distinguished speakers. The International School of Shwayfat Sabis Alumni Association encompasses the Sabis school network of schools in Lebanon. Our mission is to reinforce lifelong intellectual, professional, and personal connections among the members and to serve the community. Our responsibilities include scholarship funding, career counseling, alumni reunions, community services, community projects, and last but not least, service talks and webinars. This is the first in a series of informative webinars addressing key issues lined up for this year. The COVID-19 vaccination is a very important subject to all nations. It is in particular important for ours. Our nation, unfortunately, suffers from political instability, it suffers from economical hardship, and recently recovering from the Beirut explosion. It gives me great pleasure this webinar, and I have to thank my friend and our alumni, Dr. Samah Abdel Baki, who have put this all together. And of course, Professor Sinert and Professor Ghassan Dbaibo, thank you very much for participating. Dr. Samah has graduated from International School of Shwayfat Sabis in 1997 and is currently a medical doctor based in New York with a clinical focus on neurology. He has led the clinical research and established the technological and clinical relations for incorporating the wireless micro-EEG platform in the workup of patients presenting with neurological emergencies. With colleagues at State University of New York, he was able to discover a drug pair that was unusually potent in treating cognitive deficits after a traumatic brain injury. For those among us that are not in the medical field, basically they managed to identify two simple medications that are already available, having the combination of these two have multiplied their efficacy and the results in cognitive illnesses. And the US Army honored this research by recognizing it as one of the most outstanding research projects funded by the Congressionally Directed Medical Research Program in fiscal year 2007. This same platform is currently being utilized to identify clinically undetected seizures, guide treatment, and reduce neurological damage and mortality for the current COVID-19 patients. So Dr. Samah's work from the past is being used now. And I'm grateful for Dr. Samah to have put this webinar together, and I'll leave the floor to Dr. Samah. A few things I'd like to point out. Please, non-speakers, please keep your microphone on mute. And the other thing is that anybody that has got questions, please put it on the chat and we'll get back to it after the end of the lectures. Thank you, Dr. Samah.
Thanks, Dr. Eid. Thanks, Dr. Eid. It is a phenomenal introduction. I truly appreciate you taking the time to express that. It's truly an immense honor to be part of this webinar or to be part of any activity that pertains to this great empire called Sabis. I'm truly indebted to Sabis, to the International School of Shwayfat, this great entity that taught me how to deal with uncertainty, how to revise decisions and expectations when more data becomes available. Sabis taught us how to accept not knowing definitive truth, but still express a willingness to hear different arguments and suggested solutions. I graduated from Sabis with a school of thought, with a culture that glorifies decisions resulting from our best efforts at fact-finding, and continue to be critical of the administration of such decisions, continue to challenge the facts, to question such facts. I'm hoping that with this interaction, I will abide by what I learned at Sabis, and that is highlighting the importance of properly interpreting data before applying them into practice. That's one of the many ammunitions that I took from Sabis to my current profession as a clinician and researcher. This is what's key in medicine. As we always say, medicine is not an opinion or what has been working in the past. This worked in managing prior viruses such as Ebola. Let's try it for COVID-19. This is not medicine. Medicine is about data and meta-analysis, where results of multiple studies addressing the same question are combined to provide an answer. Again, I was happily pulled into this webinar given my recent focus on delivering neurology care to patients with COVID-19. My intent was to modify the current neurology service to accommodate patients with COVID-19 by instituting policies or by adapting new protocols that can allow for admitting the maximum number of COVID-19 patients without compromising care. What I did was very much under hospital restructuring during periods of crises. What I've been doing is now, fortunately, less controversial and somewhat standardized across many hospitals all over the globe, thanks to telehealth and globalization. What is more controversial and carries a bigger impact on public health and still requires its engagement is vaccination, which is the topic of today's webinar. Engaging the diverse public in getting vaccinated requires at minimum challenging conspiracy theories and misinformation that continue to spread like wildfire on the media. Again, the intent of this address the many emanating from our best efforts at fact finding. To that end, we're hosting Dr. Richard Sinert and Dr. Ghassan Dbaibo. They're two professors, actually. Dr. Sinert has been my busiest hospitals here in New York. He has led multiple trials that resulted in a change in clinical guidelines at many venues. I was involved in at least 2 clinical trials led by Dr. Sinert. He's an astute interpreter of clinical data and a major critique of methodologies. We're privileged to have him contribute to this discussion today. I'm also incredibly pleased to have Dr. Dbaibo, Professor Dbaibo, as our expert speaker too. He's a professor of pediatrics, biochemistry, and the director of the Center for Infectious Diseases Research at AUB Medical Center. Dr. Dbaibo, as you've seen him probably and you know about him, had been a fearless ambassador combating misinformation revolving around C19, around COVID-19. Dr. Dbaibo's foundation is established by over hundreds of publications in the peer-reviewed primary clinical literature. He taught me how to always acknowledge mechanisms underlying clinical phenomena. Is Dr. Dbaibo on board or not yet? I'm introducing him without him being here. Is he here yet or not? Did he join? Not yet. Okay. In the hope of being explicit, we decided to split this discussion into 2 parts per speaker. A part that addresses the data available on the multiple vaccines, immunity post-vaccine, safety. This will be tackled by Dr. Sinert. The second part that mainly tackles logistics, vaccinating vulnerable patient populations, the pediatric population or kids with chronic diseases will be addressed by Dr. Dbaibo. Now, and again, being cognizant of time, I'm going to pass the virtual podium over to my mentor, to our beloved person, mentor, Dr. Sinert. So Dr. Sinert, please go ahead.
Well, thank you very much, Samah. And Samah and I have worked together, and he's a great researcher just by himself. But we have worked together for many, many years, and that was a very nice introduction. You know, I'm not, unlike many of my younger residents and medical students, not a big practitioner of online media. So a lot of the myths about the COVID-19 vaccine, I haven't seen firsthand, but Samah and I have come up with some questions and to talk about some of the myths. And hopefully we'll be able to dispel these myths and convince you to get vaccinated as soon as possible for COVID-19. Because I have gotten my vaccination. In fact, I was the first one in Kings County, the hospital I work at, the first physician to get the vaccine. You know, you have to put your faith where and actions where your faith are. So I am fully vaccinated, and I want to convince you to become fully vaccinated too. And to help you do that, Samah and I have come up with some questions that people have asked us to try to dispel some of the myths. And Samah, would you like to introduce the first question?
Absolutely. We're going to pass the screen over to you so that you present your slide deck.
Sure.
If you have it ready. Yeah.
I have it ready. And
yeah, I may interject as you go. I may interject as you proceed with answering the questions.
As always, I would hope you do that.
Sure. Ms. Zaina, is there a way he can have the screen?
You have to give me.
Yeah.
You have to
Ms. Zaina,
give me the permission to do that.
Yeah, Ms. Zaina, is there a way we could pass the screen on to Dr. Sinert? Is this at all possible? He has the visuals. He must share them. Dr. Eid, who's in charge of that? Who's going to pass the screen over to Dr. Sinert?
Zaina is doing
Okay, great.
Hello, everyone. Yes, now he can share the screen. And
thanks a lot.
With us. Welcome, Dr. Dbaibo.
Dr. Dbaibo, you missed the introduction. You know it, I'm sure.
That's
good.
Okay.
So now we're having Dr. Sinert. Yeah, great. Thank you.
Can you see my slides?
Yeah.
Yeah, we do see them.
So the first
slideshow.
Great, and I'll just go through it quickly. I don't want to spend too much time, and I don't have many graphics. This is one of the few graphics I have because one of the first questions many people had about the vaccine, especially the Pfizer and Moderna vaccine, which are mRNA vaccines, which I'm going to talk about in a few minutes, is unlike traditional vaccines, this vaccine was developed very, very quickly, much faster than other vaccines. And this has caused people to doubt how the vaccine was made, the safety, and how it was made. And I want to talk just a few minutes about the mRNA vaccines, the Pfizer and Moderna one. The Moderna vaccine actually was produced within 25 days of it being described in Wuhan, the genetic makeup of the virus. And Pfizer and a company in Germany called BioNT developed the Pfizer vaccine. Here's some background.
Yeah, there's so much background noise. Oh, I'm sorry, Dr. Sinert. Whoever is unmuted, please mute yourself. Please, in the interim, till we finish, please mute yourself.
So traditionally, vaccines, the traditional vaccine, which is either a virus or a part of the virus that is grown and encapsulated in another virus, this takes made, and this took years. The HIV vaccine is still being made because it's being made in this old-fashioned traditional vaccine kind of methodology. Where the mRNA vaccines, the mRNA, if you remember, is just codes of nucleic acid, which code for part of the COVID-19, the SARS-CoV-2 vaccine, the virus. And then it's encapsulated in a fat globule, and that's what gets injected into you. The fat globule containing the instructions to make the antigen that makes the immune response is in a fat globule that's injected into you. And that is because of previous SARS virus 2002 and 2012, the drug companies were primed to build this. They were also making mRNA vaccines for chemotherapy against cancers. So these two companies were primed when SARS-CoV-2 came out and the genetic makeup was elucidated, and especially for one of the spike proteins, one of the proteins on the surface, it was very quick to make this vaccine. So although it came out much faster than traditional vaccines, and it's a novel vaccine, the studies, which I can talk about in a few minutes, show that it's incredibly effective. The Pfizer vaccine, 95% effective. The Moderna vaccine, 94.1% effective. So just because it came out quickly, you have to remember it's a new type of virus, new type of vaccine. Yes.
Yeah, if I may just interject, so that we debunk that myth that they did it in a rush.
Right.
The vaccine wasn't done in a rush at all.
No.
The vaccine, the technology has been ongoing for the last 20 years. Let's just agree or debunk that myth or conspiracy theory that they rushed it, that the whole entity rushed that vaccine. It wasn't rushed at all. The technology has been there for so long, and even for SARS and for chemotherapy before COVID-19. Now we're using the mRNA technology for the COVID vaccine. go ahead. Sorry, Dr. Sinert. I just want to make sure.
So the
we
next
recapitulate.
question is cannot, because there is no part of the virus in the fat globule that's injected into you as the vaccine. There's no COVID-19. There's not even part of the COVID-19. The mRNA is an instruction set for you to make the antigen to make the immune response. So there is absolutely 100% no way that you could get COVID-19 from the mRNA vaccines from Pfizer or Moderna, or from any other vaccine that's being produced. The AstraZeneca, Oxford, Sputnik 9, the Chinese vaccine, there's no way that it is impossible to get COVID-19 from the mRNA vaccines or any vaccine that's out there now. Next question.
Great.
So which vaccine is better? So there is actually 124, at last count, I counted recently, there's 124 candidate vaccines that are being produced around the world by different pharmaceutical companies and different governments. At present, in the United States, the Pfizer and Moderna vaccines are approved in the United States. And I'll spend some time talking about them because the Pfizer and Moderna vaccines, they're the results of the phase 3 study, which tells you if it's effective or not, have been published in peer-reviewed articles. And you know, being published in peer-reviewed articles is the gold standard for talking about a new medication or a new vaccine. The other candidates, and I'm a believer, and Samah will tell you this, in evidence-based medicine. And the evidence comes from peer review articles that were published because they've gone through the mill. They've been tested by reviewers, they've been tested by the public, where the other studies, although they may have come out with phase 1 or phase 2, early studies, or have made public announcements about their effectiveness, until published articles are out there, the gold standard has not been met. Should I go on, Samah?
Yes, please do. Excellent. Please do.
So what were the adverse events? Because these are really what happens, what's the worst outcome? Remember, there are, we're going to talk about the effects that you should get or should be expected to get. These are unexpected events. For the Pfizer, there were 4 serious adverse events. One patient had a shoulder injury, probably from the injection. They had a bump under their armpit. One had a slight increase in their heart rate, and one had right leg paresthesias. But none of these were directly related to the drug. This is what happens when you give 15,000 people the drug. You're going to get some people who have these adverse events, but not related to the drug. 2 participants died, and 4 in the placebo group, but they were not related to the drug, at all. These were just because we had 30,000 patients in the study. Out of 30,000 patients, 1 or 2 are going to have a bad outcome, just expected. And no deaths were considered by the investigators related to the vaccine of placebo, and there were no COVID-associated deaths. So the adverse events, this is a very, very safe drug.
Excellent. So I just want to really echo what you just said, Dr. Sinert, and just put some numbers, quantify what you're saying, just so that we're clear. This is another myth. The life-threatening events are similar amongst both groups, the group that took the vaccine as well as the group that took the placebo or the water. Just so that we know that it is rare and it's expected to happen when you vaccinate that many people. And apart from the fact that it is rare, it's also, it existed in the placebo group, the group that took water, not the vaccine itself. Right. Go ahead, Dr. Sinert. Sorry, very quick.
Also true for the Moderna vaccine. There were 3 cases of Bell's palsy, which is an inflammation of one of the facial nerves. There were some hypersensitivity reactions, some allergic reactions in both the Pfizer and the Moderna, but at a very small percentage. 2 deaths in the Moderna group. One was a cardiopulmonary arrest and one was a suicide. And the same events happened in both groups. Like Samah just said, There were no deaths related by the investigators to the vaccine or the placebo. No COVID-19 associated deaths were observed. And again, just as Samah said, the same number of adverse effects happened in the placebo, the patients who just got water, to the patients who got the vaccine. So this is very, very safe. So what should you expect?
Excellent.
When you get the vaccine? So vaccines work by causing an inflammation and an immune response in your body. So you should expect a local reaction, and you may even have a systemic reaction. The local reactions are pain at the site. You got an injection. You may have some redness and some swelling at the site. These are local reactions at the site. And systemic reactions, you could have a fever, headache, or myalgias. It's just kind of like getting a small cold. Remember, vaccines work by causing your body to have an immune response. All of these, the local and systemic reactions, are manifestations of immune response. In fact, if you get these reactions, you should be happy because your body is it shows your body is making immune response. So not only should you expect it, you should kind of hope for this. And they're all mild. They can be treated with Tylenol or Motrin or ibuprofen, whatever you want. Treat it like a regular immune response. But there were no serious immune responses.
Excellent. Anyway,
is that clear?
Very clear to me.
So there were some questions that Samah and we saw in social media that are not answered by the papers and not answered by the two studies. That's why I have question marks here. And we're gonna go over these questions, and I'm gonna show you the papers answered the questions previously to this, but the results of the papers do not get to these questions. But I have some ideas about how we should answer them.
Great.
Are there specific individuals who should not get the vaccine? Children under 16. Well, the Moderna was 16 and greater, and the Pfizer was 18 and greater years. So we don't know. But both studies for the younger patients are ongoing. And when we know, I think it'll be safe for them. Pregnant or lactating, again, there were in both studies, the Moderna and Pfizer, patients who got pregnant during the time that they received the vaccine, and there were no unfavorable outcomes. But these were small numbers of patients. So if you're pregnant or lactating, should you get the vaccine? Probably yes. Probably yes, although it wasn't studied. And it probably won't be studied until we give it to 1 million patients and see what happens. But there is no reason that these vaccines should have any teratogenic, any problems with fetal or ongoing pregnancy. If you're immunocompromised, HIV, AIDS, renal transplant, if you're taking some immunomodulating medications, for rheumatoid arthritis or psoriatic arthritis, yes, you should definitely take it. In fact, those patients should be further up and prioritized on the list because they are more prone to COVID-19 and the bad effects of COVID-19. So immunocompromised, HIV, AIDS, patients on immunomodulating drugs should definitely take the drug. Will it be as effective? Well, because they're immunocompromised already, their immune system is not working up to snuff, either because they have a disease or they have a medication that is keeping their immune system down. They probably won't have as good a result as patients who have a fully intact immune system. But because they're immunocompromised, they should get the COVID-19 vaccine. Is that clear?
Yeah, I'm wondering. Yeah, sorry to interrupt, Dr. Sinert. I'm wondering if this is clear to the rest of the audience. Is this making any sense? Because really, we're trying to address each question separately, and we're trying to be very explicit, responding to each of those controversial questions that are not necessarily addressed by the study or by the literature. Is this clear to the audience? I wonder if there's a way we can know by responses on the chat box. Probably.
Yeah, what? We could cover the chat box at the end, and I will answer every question.
Yes, that would be good.
Does that come up?
That would be good. Yeah. I don't want to run out of time. Go ahead, sir.
The next question is: should you get the vaccine if you already had COVID-19, or you were positive for antibody, or you had a positive PCR? Really, kind of no one knows because this wasn't studied in the papers. But from my reading of the vaccine literature, yes, you should get it. Maybe you should wait a little bit. Some people say you should wait 90 days after an acute infection, because probably at least in those 90 days, you're covered by antibodies from having the infection. But then I think you should definitely take the COVID-19 vaccines, because we don't know if you have a COVID-19 infection, how long immunity will last. But at least 90 days looks like what you're covered in. But after 90 days, you should definitely get the vaccine if you had COVID-19 infection or you were asymptomatic test positive.
This is a very important point, really. It's a central point which I'd like to highlight as well. So yes, even if I got COVID, even if I'm PCR positive for COVID, I still have to take the vaccine. Maybe wait 90 days, but I still have to take that vaccine. The literature doesn't address that point yet. Good. Dr. Sinert.
The next question, there were cases in the UK, 2 cases of anaphylaxis and a couple of cases in the United States, which anaphylaxis is a severe life-threatening immune response in patients who got the vaccine. In the Pfizer study and the Moderna study, which had 15,000 patients got the vaccines in both groups, there were no cases of anaphylaxis. But it's possible, and it happened. Why it happened, no one knows. But if you have allergies, especially to milk or eggs, in previous vaccines, you could still take these vaccines, because these vaccines, the mRNA by Pfizer or Moderna, are not made in products. And unless you have a history of anaphylaxis to different stimuli, then I think you should be careful about getting it. But if you just have allergies and you're an allergic person, you certainly can take it. There are some warnings if you have a history of anaphylaxis to other antigens, other chemicals, then you should be very careful about it. Status. That means they put the thing up their nose and they tested to see if in the Moderna trial, the people who got the drug had less carrier status. So there was less number of patients who had asymptomatic infections in the Moderna drug compared to the Moderna placebo. So at least for the Moderna, there's a signal. It's not proof that it may decrease infection or transmission of the disease. Pfizer now is studying it, and now every drug company who's doing a vaccine is looking at this subpopulation. You should still have a mask, social distancing, and all the other regulations about passing it on and getting the infection yourself and passing it on to your relatives and other friends. So at the moment, if you get the vaccine, you should still practice, safe masking and social distancing until 60 or 70% in your local population get the vaccine. Then there's a thing called herd immunity, so that the chance of transmission, because so many people around you have been vaccinated, the chance of transmission to a serious disease is so small, then maybe we're over the hill. But until 60 or 70% of people in your local population are fully vaccinated, even if you are vaccinated, you should still be very careful about masks and social distancing and hand washing, of course.
Great.
What if you missed the second dose? So the Moderna and the Pfizer require 2 doses, an initial dose and then a booster. The Pfizer is 3 weeks, the Moderna is 4 weeks. If you miss the second dose, can you get a second dose from a different vaccine? It's probably not a good idea. because both vaccines make a specific antigen and have a specific immune response. And what you want to do is boost that specific immune response. So if you get the Pfizer one, you're going to have a small immune response to one specific type of virus particle, viral antigen. And if you get the Moderna, you're only having a specific to that. You don't really get the boost from either. And both of them you need to boost. The Johnson & Johnson vaccine, which the data just came out today, I haven't seen yet, only requires one dose. So it'll be much easier to get. But from now, if you got a Moderna vaccine, get the second dose of Moderna. If you get Pfizer, get the second dose of Pfizer. How long will immunity last post-vaccine? Well, the studies that were published by Moderna and Pfizer only had 2 months of data. And at 2 months, the Pfizer was 95% and Moderna was 94.1% effective. So we know that immunity lasts at least 2 months and probably longer. Does it last a year? We're going to have to wait for further studies. And we're going to have to wait for a gigantic population to get this drug. And we're going to have, that's the phase 4 study, where we look at millions of people getting the drug and to see who gets infected or who doesn't get infected and how long it lasts. We can check somewhat by looking at antibody response in blood tests, and they're doing that.
Yes.
But it's not the same as knowing if you have an antibody in your blood and what level of the antibody prevents the infection. No one knows yet. And we're going to have to do kind of the phase 4 study where millions of people get this to know how long immunity lasts. But the important thing is don't wait. Get the vaccine as soon as you can, because then you got at least 2 months of coverage. And for someone who saw, you know, Samah didn't mention this, but one of the hospitals we work in at University Hospital of Brooklyn was a COVID-only hospital.
Correct.
So we took care of hundreds and hundreds of patients of COVID-19. And we saw, unfortunately, a lot of people die and have terrible outcomes. And once you see that, you are sold on the vaccine.
Yes. Yes.
And no matter what social media says about, you know, 99% of people who get the infection, it's not so bad. The 1%, or actually it's probably maybe 1.5% who get the infection who have a bad outcome. And it's not limited to young people or old people in all ages, including children. You don't want to get it and you don't want to test it. So you have to get the vaccine. Can someone receive more than one vaccine? Again, no one studied this. And since no one knows how long the vaccine protects you for, no one knows if you get one vaccine and then another vaccine comes along in another 6 months, should you get it? There's no data one way or another. So I can't really tell you, but I will tell you, like the last questions, if you get the first dose and you need the second booster, get the same vaccine. Now, you know, you've heard that the virus mutates, that it changes characteristics. And you've heard about the British one, which is unfair to Britain because they just did the test early and they found it in Britain. I hate to call it the Britain variant. It's B117 variant. I think we should call it that. Like we shouldn't call it the Chinese virus. God forbid we should call it that.
Like our president, like our ex-president. That's what he called it.
we shouldn't call it by where you find it. Like the Spanish flu had nothing to do with Spain.
Correct.
So the variants that have been identified in the UK, South Africa, and Brazil are a little bit different because viruses mutate, because there are trillions of these things and they're evolving all the time. And like the flu virus, we get the flu virus every year because it has a very, very high mutation rate. Now, the SARS-CoV-2 that causes COVID-19 does not seem to mutate at the same rate as the influenza virus, but we're really going to have to wait to see in another 6 months or another year to see if we should change the vaccine to make it better against one of these variants. So far, these 3 variants, the Moderna and the Pfizer vaccines, those 3 variants, it is effective. but we don't know in the future how fast this is going to mutate, how fast it's going to change, and how a vaccine is going to be effective. The one way we're going to know is we're going to give it to millions of people, and we're going to do good surveillance about the new variants of the virus, and we're going to see whether you can get reinfected. If a large number of people get reinfected, then we're going to have to make a new vaccine. But since the mRNA technology is so easy to change, and this is why it's so important, the mRNA vaccines, because you can just change the mRNA a little bit and make a new vaccine. You don't have to grow up millions of virus particles and test them. All you have to do is change the code in the mRNA, and it should be able to be effective against new variants in the future. So should you receive more than one vaccine? There's no reason to at the moment because both vaccines work very well against the variants that are coming up. But in the future, we may need another vaccine. We don't know yet. Is that
This
clear?
is awesome, Dr. Sinert. Amazing, amazing stuff.
Should folks at risk travel to receive a vaccine if not available in their home and city or countries? So I understand the push to go to different places, but there's a risk to traveling. I mean, one of the ways to prevent getting COVID-19 is not to travel. And not that airplanes are so unsafe. Airplanes seem pretty safe, but I think the air terminals are not so safe. And also standing in big lines to get on the airline is not such a good plan. So should you travel to get a new vaccine? I think the risks of traveling and getting COVID-19 while you're looking for a vaccine, and also that if you travel to a place, there's no guarantee you'll be able to get the vaccine in that city or country. Even in states in the United States, that people are requiring state IDs that you could only get vaccines in the state that you live in.
Yes.
That vaccine. So I'm sure these kind of restrictions are going to occur in other countries. And I would hate to see a large people traveling. I'm really upset about people traveling in the United States, you know, over Christmas and over Thanksgiving and over the New Year's. That was crazy. That made this big spike that we're seeing now and this big spike around the world. So I think traveling is not safe yet. So I think travel to get the vaccine is probably not a good idea. So I think that's the end of my talk. I've given these references. And I've given some websites in the United States. I'm sure Samah could give you websites around the world.
Sure.
To look for more information. And you know what I like to do is, this is a picture of my new puppy. I don't know, in foreign countries, in the United States, everyone got a COVID-19 puppy because we couldn't leave. So, you know, the animal shelters emptied out, everyone got a dog, and then everyone got a puppy, and we got a puppy.
Except me. Except me.
Except you.
I have a phobia. Yeah. If I may, this was phenomenal, Dr. Sinert. I'm beyond appreciative, really, of the flow of info and the way you presented. I just want to pass very quick questions, and thanks to Dr. Dbaibo for responding to the questions behind the scenes. Again, thanks a lot. But before we switch to Dr. Dbaibo, to Professor Dbaibo, question on the sample size, which is, again, I love that question from one of the medical doctors attending that seminar. The study that we mentioned in the very beginning, where we showed less side effects, if you will, the sample size, I would say, was 37,000 patients.
Well, the patients who got the vaccine in the Moderna was 15,000, and in the Pfizer, 15,000. The total number, including the placebo, was 30,000 in both groups. But the sample size was 15,000 in the Moderna who got the vaccine, who actually got the vaccine in their arm, and about 14,000 in the Moderna, 15,000 in the, so the adverse effects are, the denominator is 15,000.
Great. Thanks a lot.
If I may ask, the sample size that was done for Pfizer and Moderna, how does it compare when you do other vaccines? For example, if you are doing a simple vaccine for rubella or whatever, any other vaccines that we do, what were the sample sizes before they declared?
They're similar.
Question.
They're similar. They usually use about 30 to 50,000 patients in both.
Exactly. So this is the point that I'm trying to make is that there is this conspiracy theory in that the messenger RNA vaccines have been done very quickly. true, it's been done very quickly because we have got a pandemic and everybody is very eager to get these studies done as quickly as possible. And when it came to gathering patients, it was very easy to get this number of patients in a very short time because of the pandemic. While otherwise, if you are doing standard studies for other vaccines, it takes you a longer time because there's no rush, there's no panic to make the other vaccines. So people need to know that the population that has been tested on is very similar to other vaccines. There is no difference between the side effects between the messenger RNA vaccines and placebo, and it does not make much difference between that and other vaccines that are deemed now safe and efficacious.
The other benefit that I'll tell you about the Moderna and the Pfizer studies is they included a significant portion of patients of color, which have been left out of other pharmaceutical studies in the past. I think both of them had 10 or 12% African-American patients of color and 25% Hispanic populations in both. So the studies were not only done quickly, but also covered a broad range of patients, both ethnically and racially, and around the world.
The other thing I'd like to add is that with regards to the messenger RNA vaccines, the two vaccines we keep talking about, is that you get the conspiracy theory in that this is a new technique that is not tested. Well, it is very tested. It's not a new technique. It's an old technique, but now we are applying it to vaccines.
We said that. We said that.
Yeah. But on the other hand, that the other vaccines, like in China and other places, is that the numbers of the participants, we don't know if they match up because there isn't adequate publications on these vaccines.
Great. Okay. So now, thanks a lot. I may have to again give the floor to Professor Ghassan Dbaibo. And again, I'm very appreciative, Dr. Sinert. This was great. This was very explicit. The flow was very interesting and easy to follow. Professor Dbaibo, now again, it's your turn now. Thanks a lot for responding in writing to the answers to the questions that we've been sending on the chat box. So now is the time. I think we need to give you the screen. Ms. Zaina may have to share the screen with you so that you present your slides. Some of the questions we would like you to highlight or even unpack the questions that pertain to the vulnerable patient populations, including the kids. I've been receiving many questions on what would I do if I have a child under 16 years of age? What do I do in terms of vaccination? So now is the time. Thanks. Thanks, Professor Dbaibo. So let's give him the screen, please.
I hope you can hear me well.
Clearly. Thanks. Thanks a lot. Thank you.
Do you see my presentation now or not yet?
Not yet.
No, not yet. Not yet.
Okay, so I need to get the permission, I think, to...
Yeah, we need to give it to you, actually. It's our bad. Yeah. Now we can see it. Now we can see it. Yeah.
Okay. So basically, what I will do is I will answer the questions that were sent to me one by one. But first, I have to disclose that I do have a conflict of interest because I was invited by Pfizer to join their advisory board on COVID-19 vaccine back in December 2020, and I'm still a member of that advisory board. And basically, just for people who don't understand how this works, Pfizer shares with us as advisory board members some of their results of studies, including some unpublished studies, and they usually try to get some input as members of the advisory board on how to explain or how to interpret the results that they are getting. So the first vaccine that the first question that I was asked was which vaccine will we get first? And in Lebanon, we're getting the Pfizer BioNTech vaccine first. We're expected to receive it soon in the next 2 or 3 weeks. The generic name of this vaccine is tozinameran, and these names usually are assigned by specific organizations. The TOSI is a term that was assigned by the WHO to refer to all COVID-19 vaccines. The MERAN is the mRNA code for vaccines. So all future RNA vaccines are going to have the MERAN at the end of their scientific or generic name. The brand name for the Pfizer vaccine is the Comirnaty, which is an acronym that is supposed to include several terms, including immunity, RNA or mRNA, which is in the middle of that word, and COVID, where the CO is at the beginning. And the Comirnaty sounds like communities. So it's supposed to reflect what this vaccine is supposed to do. The composition of the vaccine, as Dr. Sinert indicated, it has the modified messenger RNA molecule that corresponds to the SARS-CoV-2 spike protein. This is the protein that helps the virus enter the cell by binding to the specific receptor on host cells. And this is the key molecule in inducing immunity. The next four components are all lipids, including our friend cholesterol and three other lipids whose function is really to stabilize the RNA molecule. The RNA molecule is very sensitive, can be degraded very easily in the environment due to the presence of RNases or enzymes that degrade RNA. And that actually has been the challenge over the past 30 years since we've been working on RNA vaccines, is to try to stabilize the RNA long enough so that it can be delivered to the host. And finally, success was achieved in the past 2-3 years. It hasn't been long since the right lipid envelope or capsid that has been in the works came to reality. And in the case of Pfizer, these are lipids that were used. And these actually may be the most likely components in the vaccine that may, in rare cases, trigger anaphylaxis. The components on the right side of the slide are very simple salts, very harmless, not expected to cause any kind of a problem. Now, this question, the vaccination in certain patient populations, pregnancy, immune-compromised patients with autoimmune diseases, and cancer. The current recommendation is not to vaccinate pregnant women. As Dr. Sinert says, it's probably going to be very safe and very effective to give to pregnant women, but it's not usually recommended to give vaccines during pregnancy unless they have been studied for safety in pregnancy. The only two vaccines we give to pregnant women are the flu vaccine, the killed flu vaccine, and the diphtheria, tetanus, pertussis vaccines. And these vaccines have been specifically studied in pregnant women to be able to deliver them. Now, I think the decision to give to pregnant women or not is going to be on the with the governments, with the ministries of health. because Pfizer has asked the different countries that are going to buy the Pfizer vaccines to kind of release Pfizer from any kind of indemnity, any responsibility for any side effects. So it comes back to the Ministry of Health to decide whether pregnant women are going to receive the vaccine or not. And our Ministry of Health in Lebanon decided that pregnant women should not get the vaccine, and women who are planning to get pregnant within 3 months, they should also not get the vaccine. So we have to keep that in mind. As for the other groups, immune-compromised patients and patients with cancer, they really should get the vaccine. Although, because they have a weakened immune system or not properly functioning immune system, their response to the vaccine may not be optimal. So they may have an immune response, but it may not be the best immune response that you want, as you would get in an otherwise healthy individual. Similarly, people with autoimmune diseases, that are diseases where the immune system somehow attacks the body of the person due to a dysregulation in the immune system. These people suffer from all kinds of clinical symptoms and sometimes are on immune suppressive treatment, that is medications that weaken the immune system to try to control this autoimmune phenomenon or autoimmune attack. And those patients are also at risk from COVID. They get serious complications with COVID. So definitely this group of people should get the vaccine. And again, their response to the vaccine will depend on how much immune suppression they are under, how much immune suppressive treatment they are getting. If the treatment is very strong, they may not respond very properly. If the treatment is weaker or gentler, they will probably respond and will be protected. Here we need to keep in mind that COVID-19 infection itself can launch a variety of autoimmune phenomena and diseases. Should folks at risk travel to receive the vaccine if not available in their home cities, countries? I think you asked that question also to Dr.
Yes, it overlapped between you both.
The response is the same because
yes,
travel itself is a high risk for exposure. So it's not a good idea to travel to get vaccinated. This question is about flu shots and COVID-19 vaccines. Can they be taken together? Now, in vaccinology, co-administration of vaccines usually has to be studied to ensure that when you give 2 vaccines or 3 vaccines at the same time, they are not going to interfere with each other. Because when you deliver several antigens at the same time to the body, sometimes there is interference in the immune response that makes the response suboptimal for some antigens. So when we want to answer this question, we have to actually do studies to say that, you know, giving these 2 vaccines together is not going to affect the immune response. And so far, there hasn't been a study to look at co-administration of the flu vaccines with the COVID-19 vaccines. So the answer so far is not to give them together and maybe space them apart. Usually when we say space apart, that is a 4-week period. But the expectation is that we should not have any interference, but we really need to confirm this by the respective studies. The next question is about the new COVID-19 mutants. The more accurate question would be about new SARS SARS-CoV-2 virus mutants, because COVID-19 is actually the disease, whereas the SARS-CoV-2 is the virus. So mutants are expected to continue to evolve as the virus is mutating over time. But very recently, both Pfizer BioNTech and Moderna both published results indicating that their vaccines can still neutralize the new emerging strains, both the British and the South African strains. So far, the vaccines are still good for the emerging mutants. But in the future, as the virus continues to mutate, we may reach a point where the new strains may diverge sufficiently from the vaccines that it may need new vaccines to cover that. And again, as Dr. Sinert, I think, mentioned, it may be possible in the future to have multivalent vaccines, that is, vaccines to cover more than one strain that will be circulating in the future. And this will end up being similar to what we have gone through with the influenza vaccine. Influenza vaccine started with a single strain, then it became a bivalent, then a trivalent, and now it's a quadrivalent vaccine. So this is something that is very likely to happen over the future. This question is about the role of COVAX /WHO and equitable access to vaccine. So there is a accelerator a platform that was launched by the WHO, the European Commission, and France for the development of both three pillars for COVID-19: diagnostics, treatment, and vaccines for COVID-19, with the intent that these pillars should have equitable distribution across the globe for different countries. COVAX is the vaccine pillar of that accelerator platform. And this is coordinated by Gavi, by the Vaccine Alliance. Gavi is the Global Alliance for Vaccines and Immunizations. And it's funded partly by the Gates Foundation, but also by other funding organizations and philanthropists. The Vaccine Alliance and the Coalition of Epidemic Preparedness and Innovations and the WHO. So they all came together to set up COVAX, whose aim is to ensure access to COVID-19 vaccines by all countries of the world, regardless of their wealth. And their aim is to get 2 billion doses by the end of 2021. Now, they are relying on two main strengths. One is to be able to get significant from other organizations to support this effort. And they also rely on advanced market commitment. To basically, what advanced market commitment is telling the companies that come up with good and approved vaccines is that we have a commitment from 50 countries to buy 1 billion doses of your vaccine once it becomes available. So that commitment allows the company to invest in manufacturing facilities that are large enough to deliver that number of vaccines. And when you are talking about vaccine manufacturing, there is a huge investment from the pharmaceutical side to build the facilities to make the necessary vaccine number. So when they have advanced market commitment, the companies are able to invest and deliver the vaccine in a shorter period of time. So the presence of funding, the advanced market commitment, especially if a fair number of the advanced market commitment comes from wealthy countries, then the price of the vaccine becomes lower. It trends down so that the unwealthy countries can benefit from this advanced market commitment and be able to distribute the vaccine to their country people. And once the vaccines become available, they will be allocated to all the countries participating in COVAX at the same rate per population for the participating countries, so that all countries will get, let's say, 5% or 10% or 20% distributed to their population. So this is as close as equitable distribution as we are going to get.
Dr. Dbaibo, if I may interject just very quickly. So we are optimistic about the delivery, about the ETA. All what we've been hearing in the media, that there may be some delays or there may be some shortage of supplies. Do you believe that? Because it's happening even in Italy and other places. Italy is suing Pfizer for that reason.
In Lebanon, we have been reassured over and over again that the vaccine will be delivered in the second week, if not the third week of February. And this has been confirmed by the company, and we already know the flight of the first plane coming in from Belgium to deliver the vaccine, etc., etc. So we have sufficient details to kind of believe that this is going to materialize. And already the Ministry of Health has the plan in place for the delivery, the distribution, the vaccination centers. I didn't want to go into detail about that. There are
that's great.
11 centers that are going to be a storage place for the vaccine. There are 41 centers that will be vaccination centers all over the country. The identification of teams who are going to be responsible for vaccination has already been started, and the people who are going to be on the team are being identified at the different vaccination centers. So we'll keep our fingers crossed and hope that all of this will materialize as planned.
As planned.
The question about the Arab world, I didn't want to overwhelm people with detail, but in the Gulf countries already vaccination has started in Kuwait, Saudi Arabia, Bahrain, Qatar, UAE. All of these countries have started their vaccination programs, and actually UAE is doing a great job vaccinating. They're using both the Pfizer and the Sinopharm vaccine. In other Arab countries, there are variable dates of arrival for the vaccines. There's a question about the COVID-19 in the pediatric world and the MIS-C syndrome. So for most children, COVID-19 is a self-limited infection, and most children who acquire the vaccine the infection actually get a very benign illness, some fever, some body aches. They get over that very quickly. Unfortunately, for some children, there is a syndrome that occurs very rarely. The current estimate now is 2 per 100,000 who get this syndrome. And this syndrome occurs usually about 2 to 4 weeks after COVID-19 and is considered to be due to an erratic or abnormal immune response to the infection. What happens is after they recover from the acute illness, they go on for a week, sometimes 2 weeks without any problems, and then suddenly they start developing symptoms of illness again. And it's a combination of symptoms, fever, abdominal pain, vomiting, diarrhea, rash, red eyes, red lips, difficulty breathing, muscle pains, swollen hands, swollen feet, and enlarged lymph nodes. And those symptoms can all be present and can be present in different combinations. And when we examine those patients, we find that their blood pressure is low, their heart is not functioning well, they have irregular heartbeats, the heart pump is not pumping correctly, they have difficulty breathing, rapid breathing, an extra effort of breathing, their kidneys are starting to fail, they are starting to build fluids in different compartments like the lungs, the heart, and the abdomen. Their liver shows signs of inflammation, and they are not completely conscious. Their brain is getting inflamed. So it's a very serious syndrome, and they need to be treated in an intensive care setting with intravenous immunoglobulin, which is a kind of immune preparation that helps in regulating the immune response in many situations. They get steroids, high-dose steroids, to kind of try to settle down the inflammatory or immune response and try to get it a bit under control. And they require supportive care for different failing organs. So we give them medications to build up their blood pressure, help the heart pump a little bit better. And if they have kidney problems, etc., we need to help them deal with that. So most children who get that syndrome, if they are treated in a good intensive care unit, usually they make it, they respond, and in a few days they get out of the intensive care and are back in a normal hospital bed, and in a few days later they go home. But if the concern is that in Lebanon we don't have many pediatric intensive care units, and a lot of areas in the country lack that. So this is the concern, is to have enough intensive care unit beds to deal with those children. We just admitted today an adolescent, a 17-year-old with this, to our adult intensive care unit because the child had a big build. So this is something that unfortunately we've seen. This today's case would be the 5th case we are admitting at our center. And I think the last question is about vaccines for the pediatric patient population. So currently only the Pfizer-BioNTech vaccine was studied in adolescents older than 16 years of age. There is an ongoing study by Pfizer looking at children between 12 and 16 years of age. And there are plans in the future to study the vaccine in younger children. So one thing to know about Pfizer is that they decided not to develop many vaccine trials now because they are trying to prioritize vaccine delivery who really need to be vaccinated. So in the future, in 1 or 2 years, they will expand the vaccine trials to address specific populations that need to be specifically tested. And I think that might be earlier if their vaccine supply ends up being significantly improved. I think that is what I have. If there are any specific questions, I will be happy to answer them. I see a lot in the chat box.
Yeah, in the chat box. Yeah, if you want to go with the pediatric ones, just since we're at it, could we respond to the pediatric, the ones that pertain to kids in general? Okay. What do we do? Shall we give them the Chinese? I've been receiving that question repeatedly.
No data have not been studied in the pediatric population, so I wouldn't venture that way.
Absolutely.
One thing that I don't know if Dr. Sinert addressed, but one of the Chinese vaccines that is being studied in the UAE, Turkey, Brazil, etc., has given various efficacy results from 50% to 80%, depending on the country. The size of the population studies was always small, a few thousand subjects enrolled only. Nothing has been published about these studies.
Yeah.
So we don't know the safety, we don't know the efficacy. The problem with the killed vaccine, and I mentioned that in my response in the chat box, is that killed vaccines are a bit scary. We don't have any prior experience with coronavirus killed vaccines. We know from other viruses that we've tried killed vaccines that sometimes killed vaccines are a problem. They can result in something called immune potentiation or antibody-dependent enhancement, which is a phenomenon that makes the recipients of the killed vaccine prone to get a more severe disease when they get the actual illness. And we saw that in measles virus killed vaccine, and in the other pediatric virus, the respiratory syncytial virus, RSV killed vaccine. In those trials, the recipients of the killed vaccine ended up with severe measles disease, severe, almost fatal measles disease, and the same for RSV. So there was this concern that killed vaccine may have lead to a problem somewhere. And because COVID is a largely immune-mediated disease, that's where the delivery of a killed vaccine has led to a high level of anxiety among those of us who know the history of vaccination with killed vaccines.
Dr. Dbaibo, just so that it's clear to the audience, the Chinese vaccine is the killed one, is the inactivated or killed vaccine. Yeah.
Exactly. Samah, can you guide me?
Absolutely. Absolutely. Absolutely.
Chat box to identify pediatric.
I'm going to start with actually some other questions now that you've addressed the pediatric piece. The question is, how long does this last? How long does the immunity last? I think this was addressed by Dr. Sinert, but I'd like you, if possible, if you can kindly highlight that as well.
Sure.
How long do I stay immune?
Yeah. That we have, first, for those who get the infection, the best data that we have now was published just a couple of weeks ago in Science magazine, which is one of the premier publications in scientific research, shows that those who get infected continue to have T and B memory immune cells. These are the key cells that the immune system uses to fight infections down the road. That is, in the future, these cells remember COVID infection, remember SARS-CoV-2, and they were identified 9 months after getting the infection. So we have at least 9 months memory. The people who wrote the paper expected that these memory cells should last much longer than that, maybe a year, maybe 2 years. We don't know yet because we haven't been that far out from the earliest infections that have been studied. Now, so this memory will continue with us for a long period of time. The problem is, will the memory be relevant? That is, will the virus continue to change to become a different virus as we see in influenza infections? And there's another important question that was asked in the chat box. Does the coronavirus mutate too rapidly? It mutates, but at a rate lower than the influenza virus. So this is something that will help us down the road. Now, I think Dr. Sinert mentioned about the vaccine immunity or protection.
Yeah.
We're not that far out yet. The earliest enrollment in the Pfizer vaccine was back in April. So we have several months of protection so far, but we cannot tell if the protection is going to be 9 months, 1 year, 2 years. We have to remember that the immunity that Pfizer vaccine will give against the spike protein is actually several-fold higher than the immunity we get from the natural infection. So if anything,
from the virus,
the immunity from the vaccine might end up being longer than the natural infection. But again, we don't have the data to prove that now. It will take us some time to answer definitively this question.
Great. There's a question whether the vaccine has any effect on fertility. This is going to be the short answer from you, Dr. Dbaibo. And there's another question interrelated. Is it going to affect is it going to alter our DNA? The answer is no, definitely. Yes. But could you please unpack that as well?
Yes. These are two of the themes with the conspiracy theories that get circulated. And this is not the first time, actually. Polio vaccination had that also kind of a news conspiracy theory, and it led to a major problem in and the community in Nigeria has now believed that polio vaccination is going to infertility, and therefore they have avoided vaccination, and that has led to the continued spread of wild-type polio virus. Unfortunate, but this is a real challenge, and actually the WHO driven misinformation about vaccination as one of its top 10 priorities for health around the world. Specifically about these vaccines, they do not cause infertility. There is no biological or scientific method or mechanism for any vaccine, whether it's an adenovirus vaccine or an RNA vaccine or a killed vaccine, to alter our DNA in any way. What it does, it alters our immune response, our immune system. It educates our immune system so that our immune system can respond in the future to the virus when it gets exposed to it.
Great, Dr. Dbaibo. I have two more quick questions. There's, the Johnson & Johnson, there's one dosage that, again, the company declared that you need only one dosage, as opposed to all the other vaccines where you have to take, in principle, 2 dosages. A quick feedback on Johnson & Johnson's vaccine.
Well, again, they haven't published their studies yet. What they have is a press release, which are usually geared towards the investors in the company.
Marketing,
make them happy that you're going to make. Unfortunately, we cannot answer that. Yes, they said that it is a single dose vaccine. This may be due to a unique change in their adenovirus that they use to deliver the spike protein. It may relate to a dose that they have used, or a different type of I don't know. So we have to really see studies to be able to answer how well a single dose of Johnson & Johnson vaccine will be effective. But it's promising.
Nice. Very interesting, very comprehensive, really. I wonder if there are any other questions before we make Dr. Eid adjourn, or just come up with a close note.
We have a few questions on the chat.
Go ahead. Go ahead, Dr.
Answer. One of them from my classmate, Rabia Burji. He asked, would we get back to normal once we are vaccinated? And I suppose this is Professor Sinert's answer, that is that we need to get herd immunity for about 70% of the population to be immunized before we get that near back to normal, and we'll still need to wear masks and to have hand sanitizers, etc.
Dr. Sinert and Dr.
You
Eid,
agree,
do you want to comment on that? Okay, and Dr. Dbaibo, any comments on this? Dr. Sinert, you're on mute.
No, we answered this already. I think until we get herd immunity, we're still going to be wearing masks and social distancing and washing our hands. And also, this is not the last pandemic we're going to see in our lives. We have to learn our lesson about surveillance and treating and doing better work with the World Health Organization and people on the ground looking to where these viruses start.
There's another two questions which are not on the chat box. A colleague of mine had been vaccinated with Pfizer vaccine, his first dose, and before he gets the second, when should he get the second dose?
Dr. Dbaibo, maybe you want to answer that. Professor Dbaibo, if you want to answer this.
Yes, I mean, this is a very interesting question, but usually you do not vaccinate somebody who's acutely ill. So if somebody is ill at the time that the second dose is due, that second dose has to be postponed.
Yes.
Now, these cases are probably going to be collected and published at some time in the near future, because vaccination efforts are still ongoing, and there's a lot that we are going to learn from the introduction of the vaccine and getting the actual real life effectiveness of the vaccine. What are the actual side effects that are observed, and situations like this one where somebody gets COVID due to the before completing the second dose. In my expectation, I would say that if you get the first dose, you're going to have some kind of immunity building up towards the time where the second dose is due. So if you acquire COVID-19 in that period, it is very likely that the infection is going to be a mild one, and that you will get over it quite quickly. And then once you recover, then it would be appropriate to schedule the second dose for vaccination.
Okay, the other question is that participants, please move. Thank you. The other question is that, for example, in the Gulf, they offer the Chinese vaccine, the attenuated vaccine, and they also offer Pfizer. Now, for people who are in line for Pfizer, maybe there'll be few months for that for them to be eligible to get it. Would they consider taking the Chinese?
This is like the most common question I'm getting every day.
And then after that,
from
in
the
2 months later,
UAE.
they take the Pfizer again.
Yeah, let him answer. Yeah.
Can we answer that?
They ask that question. Again, as a physician and scientist, I would answer based on science.
Yeah.
I can only recommend vaccines that have been studied and the results are published. The Chinese vaccine is still a black box. We don't know much about it. So I cannot recommend it to anybody. So those people who ask me, I say, if you can get the Pfizer vaccine, please do. If you have no hope to get the Pfizer vaccine, then you are going to get a vaccine that is unstudied and unproven. I cannot recommend it myself. So this is my answer.
Thank you very much. I think we have answered most of the questions that were on the chat box. I will leave the floor to Professor Sinert. Do you have any last comments?
No, I think...
Can I make one question? This is Talal Garzuddin.
Yes, go ahead.
Yeah, because the doctor, the physician who was just recommending the Pfizer one and not recommending the Chinese vaccine, which anyway all are controversial in the sense that very short period of time has been tested these vaccines, and there is a lot of controversial issues behind it. If there is a conspiracy, whatever it is, but I'm not going to go into this. But just recently, I was informed that the UAE has been using the Chinese vaccine, and that some or other, I'm 100% sure that the authorities in the UAE would have demanded a lot of information before approving this kind of vaccines. So, and I would ask that question is that why sometimes we are more confident in certain American laboratories than those in the Far East. I agree that the whole nation, the whole production in USA has more credibility in many ways because there is more demand, FDA and other organisms before
What's the question?
authorizing.
What's the question?
So the question is why the doctor says that the Chinese one, it's not scientifically proving at the same level that the Pfizer laboratory one.
Yes,
Dr. Dbaibo.
Yeah, the process of evaluating drugs and vaccines goes through the clinical trials that study the vaccine, how effective it is and how safe.
Exactly.
And once that data is collected, it gets published, and it gets published in a peer-reviewed journal. So you send that data to the journal, and the journal sends it out to anonymous scientists and physicians who review the data and give feedback to the authors and to the journal to say that we think this is a good study and it should be published, or they will say that there is a lot of incoherent or inconsistent data that needs to be clarified before we publish that study. So there is a whole process of evaluation that goes on between doing the actual study and publishing it. Once it gets published, this to us as physicians and scientists is something that is kind of a certification that this work is legitimate. So if you don't reach that stage where the Russian vaccine and the Chinese vaccine have not reached, that is, they did not publish the results of their clinical trials, even if they submitted that to the UAE government or to another government, this still is not public information. It hasn't been published for we cannot comment. We cannot say it's a good vaccine or a bad vaccine, but we cannot recommend it or say that. But certainly we're not going to say that, yeah, go ahead and give it since the UAE approved it. This is not how things go in the
So why you think that the Chinese government or the Russian government has provided?
Please, I allowed one question. We're supposed to be all on chat only.
Chat box, please. Yeah.
Because of the time limitation, we've been on air now for 1.5 hours. It's a very interesting subject. We can talk about it until the cows come home. I think we need to finish it here. There will be other webinars online, and we'll be very happy to divert anybody's questions to the speakers. You can email us, or if you fill in the questionnaire, which is being posted on the chat box, fill that in, and we'll be able to get back to you. Thank you very much, everybody. I'd like to
thanks everyone.
Special thank you to Dr. Samah, Professor Sinert, and Professor Dbaibo. We've been very enlightened with your talks today. Thank you for.
Thanks, Dr. Dbaibo. Thank you. Thanks.
My pleasure.